Assalamu alaikum. My best wishes to all the students who will be watching this video and everyone. So today we are going to talk about a very important topic in healthcare, especially the population which has been, I would say, not so neglected, but at a higher level of vulnerability with respect to the disease and problems with respect to the disease. So we shall be talking about one of the important components in maternal and child health. As we know, this is a group which has been received a lot of attention recently. I will be primarily discussing antenatal care. So let's move on. So uh, the objectives of my session are that by the end of this session, those who are watching this video and students should be able to understand the objectives of antenatal care, and they should be able to describe the components of antenatal care. Let's move on. So as we know that pregnancy, generally said, is a physiological process, but at the same time, it has the potential of turning pathological at any moment of time. So there is a potential that problems can arise, which can risk both the health of the mother as well as the unborn child, the fetus. Therefore, antenatal care is care given to the pregnant woman. So by definition, to what it means actually, it is a care provided to all pregnant women from conception to the birth of the baby, usually from the second month of conception, according to the nature of the pregnancy. That means those who are having maybe a less complicated or a simpler or is a normal pregnancy may need less of care, but obviously they will have to visit. But more those who have complications and other things that need is maybe more care. Okay. Now, what are the objectives of antenatal care? And you can easily enumerate them. One obviously is to promote health of the mother, and then obviously to maintain, because as I said, pregnancy usually is a physiological process, not become pathological or should not affect the mother. So she should go through it nicely, preserve the physiological aspect of pregnancy, keep it physiological, and we have to make sure that it doesn't turn pathological. And detect high-risk mothers, those who need special care, provide them those care. That means there's only the opportunity once they come in contact with the system that we can give them this possibility that they can be screened for having any problem which might require special attention. Prevent complications in pregnancy, obviously, as they will be under our care. Prepare her physically and mentally to go with pregnancy, because it is usually a stressful process for the pregnant mother. And then obviously prepare her for the forthcoming tasks that she's going to perform, breastfeeding, and then teach her the craft of mother care, what the mother is supposed to do. So this is an opportunity where we'll be able to guiding her. So therefore we reduce the chance of obviously one, her landing up in problems, and then the baby also having problem later on if we do not guide her properly. Then the important aspect of it is to sensitize her for the need of family planning, which is very important because we know family population has been an issue in the subcontinent, developing countries, including India. And ultimately, if we are able to provide this care, provide good quality care, we should be able to, must be able to reduce the maternal mortality rate and the infant mortality rate. That is the goal. That will ultimately what we want to achieve with this. Okay, so what we want to see at the end of the pregnancy is that she is able to bring forth a healthy, live child with good birth weight, hopefully, at the same time, without being adversely affected by the pregnancy. She should go through it, as we said, is a physiological process. Keep it should remain physiological with minimal complications. Now, what are the components? If you look at the components, the most important component is the registration. The mother has to get registered. We'll talk about it. Then history, which is relevant in case of pregnancy, and then the real complications, the care she is going to receive. Then examinations that you have to conduct on her, and she is under our care. Then investigations we'll have to carry out. Then advice she has to be given. And then the services she's supposed to receive as part of her pregnancy, as part of the different government schemes. Now, starting with very important before we go to the actual components, the important part is the visit she makes. This care will be provided at the government facilities, or she may go on to private facility where she prefers to go. But she has to go to this place regularly, periodically, so that her pregnancy is followed, monitored for any problem that may arise, and then the problems are addressed. So ideally, the mother should visit Pregnant lady should visit the antenatal care every month in the first 7 months, or that means till 38th pregnancy. Then at least fortnightly, twice a month, till 36 week pregnancy. Then once a week till 40th week or till delivery. That means she needs usually around 4 to 15 visits should be ideally there. But if it is not possible, which many areas may not be possible for a pregnant lady to make so much visits because of her one distance and then her engagements, then the minimum recommended in the programs that are aimed at mother and child care in India are that she at least have 4 visits. First, obviously, should be ideally before 12 weeks or as soon as she comes to know about pregnancy. Then, second week's visit should be around 26 weeks. The third one around 32 weeks, and the fourth one between 36 and 38 weeks, where she is reaching or approaching her term. Okay. Now, coming back to the registration, why is it important to have registration? Because once she approaches or contacts the health facility after you're suspecting her pregnancy, she will be registered. Usually should be done within the 12 weeks of gestation as soon as possible. She will be issued an MCP card, what's called as an antenatal card, a mother or child card, which will contain the registry number, the ID number she has, which is is nationally unique. Then she'll need to have her identifying data, previous and present health history, including present complaints, if any. And this registration card is very important because one, it helps us to obviously come to know about pregnant mothers, helps us to track them, and helps us to have a very important parameter that we need to have to calculate many indicators, the denominator. And then we expect, based on birth rate, number of pregnancies. But if these rings are less, or if I'm registering less, that means we need to do more. Maybe we have to move out in this community to find out why mothers are not approaching us, or they might be getting help somewhere else, or they may not be getting it at all. So that's how this registration would help us. Now, coming to the history, so things that we need to ask before she visits our facility. What will we talk to her? What we want to know from her before we start providing health care? One important aspect is the gynecological history. It's important that we will need to know about age menarche, history of menstrual cycles, date of last period, which should help obviously us to calculate the expected delivery. Okay, then we need obstetric history, as age at marriage, the duration of marriage, the age of first pregnancy, and the history of the last pregnancy, how many pregnancy has had, then what was the outcome of the delivery, whether it has been abortion or stillbirth, how many living children she has, and how many dead children have been there, and what have been their causes. It can help us to tailor-made the care that we're providing to her in this pregnancy. Then we need to know about her medical history, so especially other diseases she might have effect on the pregnancy, like diabetes, hypertension, renal disease, maybe some reproductive tract infections, and other diseases which might be of relevance in a particular case. Then family history is important, especially looking for a history of skin disease, like diabetes, hypertension, and other things. Then twins is important because there's a history of twins. This time she may also have twins, which may increase her chance of having problems. Then blood disorders, especially say hemophilia and sickle cell disease and other things, which are important for us to know so we can accordingly guide her. Then drug intake, it's important that especially take of drugs which might be harmful, like steroids, or streptomycin, or tetracyclines, or especially in case of pregnancy, it's tobacco and alcohol, because we know these have adverse effect on the pregnant outcome. Some of the history that we need to know: gynecological history, obstetric history, or medical history, and family history, and the drug history. And the examination part is important. Once we complete her history, record her certain information, now we'll need to examine her. First, we'll need to do a physical examination, but we'll look at the her height and weight and signs of anemia, the signs of maybe jaundice. Then we may have to record our blood pressure, record our pulse. The other parameters which are important. The baseline is very important to make sure that we diagnose those conditions which need special care. Then the systemic examination, different examinations find out if there's anything abnormal. Then abdominal examination, we know, is especially done in early pregnancy. Not that relevant as the pregnancy advances becomes important, because we do it to find out the growth of the fetus. Then we sometimes find out the lie of the fetus, its position, what are the presentation as the pregnancy advances. So therefore we have what's called as the abdominal grips, lateral grips, and we have the the pelvic grip, which helps us to find out different aspects of pregnancy. Obviously, we are monitoring the, make the pregnancy as normal as possible. And the pelvic examination, this obviously becomes really important only at the time of delivery, while yes, before delivery, we have to find out whether these vaginal delivery or normal delivery is possible in this case. This patient might be having pelvic disproportion where we may not allow her to, especially with respect to her height. So this examination is available in the later part of pregnancy, at the end of the third trimester, where she is now approaching the date of delivery. Now, as far as the investigations are concerned, there are certain basic routine investigations that can be done. One, obviously, at a baseline, as soon as we come to know she comes in contact with the system. One is the urine. We examine albumin, especially with a focus in mind that we might be raised blood pressure, like what's called as toxemia. Then we examine urine for sugar to rule out diabetes. Then next we rule out any other infection. Then we had to examine her blood for seeing her blood percentage. Blood grouping is important, not only her but her husband also. The typing. Then VDR to rule out syphilis, and Gyro test to rule out HIV. Hepatitis B subpercentage test to rule out possibility of her being antigen positive, because then the plan of management of pregnancy would change. Then we examine these tools can also examine for ovarian cysts, because they are also predisposing features of malnutrition or compromise on nutrition. So therefore, they need to be identified and treated. Other investigations may be required as they are required, like X-rays usually to be avoided. And ECG and other investigations as they are required. The important thing is all the investigation must be done. Most obviously, they have to be done preferably the first visit, all of them immediately. Then the investigation will be done in the they may have to repeat her hemoglobin percentage, may have to repeat her urine for sugar, blood for sugar. So as the pregnancy goes, depending on the certain case, we'll be doing certain investigations subsequent visits also. Then we have the other investigations sometimes to rule out the possibility of congenital anomalies. Like the most important, obviously, in them is the ultrasound. It has to be done. Obviously, it should not be done too frequently, but it's important that which help us to visualize the fetus, both its growth, and then look for anomalies. And we can look for the presence of alpha-fetoprotein in maternal blood, which may help us to identify defects like neonatal defects, like spina bifida. Then we may look for other tests that can be done, if it's called as nuchal translucent scan, which will help us to rule out the possibility of Down syndrome. Usually done between 11 and 24 weeks. At 11 weeks, what we have usually is a accumulation of fluid on the skin, which is seen in this scan. The thickness has to be around 2 millimeters at 11 weeks and 2.5 millimeters at 24 weeks. If it is more, we can suspect Down syndrome. In these cases, then there will be other investigations which will help us to rule out Down syndrome, like immunocentesis could be done in the second part of second trimester to detect maladies like Down syndrome. Done in the second trimester, usually, to rule out defects, we may determine sex, which we sometimes required, which is not a recommended procedure, but sometimes we have to rule out some of the diseases for sex may be important, but obviously we have to take a proper legal permission for that. Then we may do what's called as coronary villi biopsy. Perhaps it can also be done to detect the sex of the fetus and the chromosomal status, especially if we are suspecting anomaly in this case, depending on the history of the previous pregnancies or history of such disease in the family. Then the important part of antenatal care is the advice. What advice should be given to the mother? Now the certain part that we know that during pregnancy, one thing we should remember that the pregnancy is a process which is not very common with females also. She will not be pregnant. Maybe she has only the opportunity of being pregnant once or twice, or 3 or 4 times at the maximum during her lifespan. And this pregnancy, because of the changes, she becomes very receptive. Very receptive. Therefore, they say she constitutes a captive audience, and thus health education in this phase is very effective, especially if health education is focused at the baby and her own health. So we should take this opportunity. This is a very golden opportunity for us to educate her about different aspects of healthcare of the baby, but her own or healthcare of the community and the family itself. So, what are the things that we should talk to her as far as the health advice in the antenatal period is concerned? The The most important, obviously, is nutrition during pregnancy, because we know this pregnancy is a physiological process which is usually different from her normal routine life. So therefore, her nutrition will have to change. That means she has to increase on her intake of calories and protein. Usually, calories around 350 kilocalories extra over and above what she requires, around 2200 kilocalories. Then she will need an extra of 15 20 grams of protein every day apart from her usual requirement. And then she has to, one thing, she can consume good amount of green leafy vegetables. She should consume milk, take a lot of water during this pregnancy to keep her. Then she should avoid, because it's in your society we have certain myths and conceptions that this food should be avoided, this food should not be given. Usually, most food she can take, except they say ideal to avoid spicy foods in later half pregnancy. But generally, she should take a balanced diet, but keeping view the requirement, increased requirement, she should take extra calories and extra proteins. That's important. Then personal hygiene, obviously, cleanliness is very important. She has to maintain cleanliness, take regular baths if she can, especially take care of her, the intimate areas and the breast, which she will use breastfeed later. Which has to be, or its hygiene has to be maintained. Then rest and sleep is important. Ideally, they should take 8 hours of night sleep and 2 hours in the day would be reasonable. They should take adequate rest. But one thing is important, especially in the late half pregnancy. She should take rest in the left lateral position, because the reason is that if she lies in the right position, there is the gravitas may press on the vena cava, especially may cause global attacks, and this may compromise sometimes even blood supply to the placenta. So it's better to advise her to have sleep during pregnancy, later after pregnancy, but lie on the left side. That's the ideal. Then exercise is important. She can do normal routine household work throughout pregnancy, except maybe when pregnancy is very advanced. Otherwise, she can do these things, and then a walk in the morning, evening, maybe a simple walk can be done. There's no harm. But obviously, vigorous exercise, vigorous activity has to be avoided. That may compromise the fetus. Then on drug intake, she should not take any drug without medical supervision or medical advice. She avoid all the drugs except those advised by the medical personnel or by wherever she's receiving antenatal care. And especially she should avoid tobacco and alcohol, because they're going to compromise the health of the baby. Then warning signs are important, that she has to be given advice, very important, as early as possible in pregnancy on warning signs. One is the vaginal bleeding, very important. Then like swelling of feet, severe headache, or blackouts, or loss of movements. So just some of the warning signs important for us, that she report immediately to the health center. She has antenatal bleed, vaginal bleed, if she has swelling of feet, she has severe headache, or she doesn't feel the fetal movements. So there are times when she should report, because she might be having a serious problem with the baby or with the placenta itself. Then breastfeeding, she receive advice on breastfeeding. Especially four things are important. One, start breastfeeding as soon as possible, within 1 hour. She should not. She should give colostrum, which is usually breast milk produced in the first few days by the lactating mothers. Then third, you should not give anything what's called as pre-lacteal feed. Nothing should be given before breastfeeding started. And breastfeeding should be continued exclusively for 6 months, unless there is a serious some contraindication. In most of the cases, breastfeeding should be and must be continued exclusively for the first 6 months. Then, sex relations are realized that early part of pregnancy and in the advanced pregnancy, this should be avoided. Otherwise, during pregnancy, she can have, unless, but only if she is interested. Usually, in pregnancy, sexual desire goes down. Therefore, it's only on her consent that if she is interested, she can have, but usually in a comfortable position. Okay, then we look at the services important that they should receive. As a pregnant woman, there are certain services provided by the government she's supposed to receive. And therefore, it's very important that during the period she has to be made aware of them and she has to be provided these services. So, a job, this is the job of the antenatal services. One is nutrition services, which is usually provided at the what's called integrated mother and child development services. So, we receive nutrition in terms of calories and as proteins. Apart from, we know that this is provided to the lactating mothers also and others. So she should receive this service, which will be something around 1650 kilograms of energy and 15-20 grams of protein per day at the sub-center. through this ICDS scheme. And immunizing services, she will need immunizing services in terms of tetanus toxoid vaccine, which we say she should receive 2 doses, 1 dose as early as possible, and second dose 1 month later, or ideally should be 1 month before the expected daily delivery. But no woman should be divided. Even if she contacts once the healthcare service and dental care, she should be given the vaccine. Then the second dose can even be given within the electrician. Also, if she doesn't report later on, then we may give even immunization for other diseases also. But generally, this is tetanus toxoid and hepatitis B vaccine. She may need. If she is negative, we may give vaccine, but usually it is preferred that we give this vaccine later on. But we need to find out the antigen status of this mother, because if she is positive, then we have to be careful. She may need the the baby has to be given vaccine as early as possible, which usually is the schedule now. We receive the vaccine in 24 hours, and then other doses at 6 and 14 weeks should suffice to protect the baby from getting infected. But in case the mother is positive, we'll have to make sure that the baby receives the first dose within 24 hours. Then we have the medicinal services, which is in terms of the most important component of this, obviously, is the iron folic acid. Depending on her level. If she is anemic, she may need 2 doses, 2 tablets per day for the, which say during pregnancy for 100 days. If she's not anemic, then she needs 1 tablet per day for at least 100 days. So, but she needs advice that how these tablets have to be taken and how frequently they should be taken and what other things she can take which will improve her nutrition status with respect to the iron status in the body. There are other medication which might be required depending on her condition, like if you're doing this endemic area, I mean, nutrient for malaria, if she's tested positive, or then if she's HIV positive, we may have to resort to treatment to prevent transmission of the HIV to the fetus itself. So one thing is the she wants iron. In terms of iron, the most important component of medicine is the iron follicle supplementation. Then family planning. So this is very important. She has to be talked about and convinced about family planning. It's important. She has conceived now. She's next how much time she should have for next pregnancy. It's very important. So she has to be guided, given, educated about family planning services available, and where from these services can be availed. What are the risks and benefits of having this family planning? That's important. So she will talk about nutrition, given nutrition services, nursing services, medicinal services, and then the family planning. Important. Then we have a look briefly. So these services, as we know, are provided at a facility which is usually labeled as an antenatal clinic, where this antenatal care will be provided. Now, this clinic can be anywhere, which could be a sub-center, which can visit a primary health center, or a sub-district hospital, or a general hospital also. So usually in a lower level hospital, say sub-center, even primary health center, we usually have, and in a week we keep one day, where on certain day pregnant ladies visit. In ICDS also, sometimes once a month we have what's called as VHND, where empty mothers can be found care. But generally, at sub-center it is on Wednesday they're supposed to visit, on Saturday they can supposed to visit for antenatal care. While in the bigger hospital, obviously it has to be on a daily basis because of the rush of patients they have. The functions obviously are, one is to, these clinics will provide antenatal care for the mothers with all those components that we're talking about, educate them on mothercraft and child care. Well, we're talking about what are things that she should take care of as a mother, and what are things that she should know before she takes up child care, while she is able to look after her child comfortably and effectively. And then important, the functional care is to antenatal clinics is high risk mothers screening. Identify these mothers and then refer them or provide them better care or special care. Okay, that's the main functions. Now, looking at the very important, the approach being followed in antenatal care is what's called as a risk approach. That means antenatal care, usually at early as possible pregnancy, we tend to identify mothers who are pregnant, who have some kind of, who deviate from the normal, have some important aspect of pregnancy which might land up them in problem. We tend to identify those pregnancies and then ensure that they get special care. So it's an approach towards antenatal mothers to detect high-risk cases for responsible those cases for increased maternal morbidity and mortality. So idea obviously is to reduce these two components, maternal mortality, and morbidity. It may result if you do not identify these cases on time. So they require special institutional care, provision, and treatment. So this is what called as it's a managerial approach to improve the effectiveness of MCH services, reduce mortality both in mothers as well as infants. Now, looking at the high-risk groups briefly, we have four groups in this category identified. The group one usually is in terms of mothers who are young, too young, mothers who are too old, say more than 30 years, too short, 140 centimeters, where we have a risk of having problems with especially normal delivery. Then obese mother has a problem, might have babies, very large babies, or sometimes we have diabetes. Too many pregnancies, which will obviously you may be anemic, she will develop infection and other problems. And too frequent pregnancies, again, an issue. Prolonged pregnancy, which may be a problem. We have to identify if there's a history of prolonged pregnancy previous time. This time also we have to be alert that we terminate a pregnancy as on the expected date without prolonging it. May risk both the mother as well as the fetus. And toxemia, again, has a history of toxemia. We may have to screen her to provide special care. Then, if she has a history of twins, triplets, and hydramnios, again, we'll have to be careful. If that means the mothers need special care, may have to be referred to a higher center. Then malpresentation, malposition. If there is a history, or you detect on examination that history, that we may have to refer them to a higher center immediately. Then group 2 obviously includes mothers who have had history of what's called as a bad obstetric history. History of abortions, stillbirths, or neonatal deaths, or monsters, or any other history which is relevant in this case, especially these problems. Therefore, we need to be vigilant this time that we avoid such an outcome again. Then group 3, we have others who have had history of instrumental delivery because they've had problems with the last delivery that was a obstructed labor or prolonged labor. We had to resort to instrumentation. Then we had cesarean section, especially cesarean section in this case is the what has been the indication. Was then she may again have the same indication. Therefore, we have to watch out for that. The prolonged third stage labor, she has had a problem previous times, she may again have it. So it's better to refer to a high center. Then history of antepartum hemorrhage, or this time she develops antepartum hemorrhage, having a normal pregnancy, but suddenly if somebody develops antepartum hemorrhage, she will absolutely become high risk now. She will have to be referred immediately. Or somebody has had a history of postpartum hemorrhage, again, may have this time because of many reasons like uterine atony. Therefore, the mother has to be referred immediately. So, in this case, mother also will need special care, or she should be cared at a special center or a specialized center. Then, group 4 have obviously mothers who have a history or having chronic disease like diabetes, hypertension, liver disease, lung disease, or renal disease. Obviously, so they have disease or they have a comorbidity along with their pregnancy. Therefore, they will need special care. Okay? They will have to be referred to a higher center. So these are the four groups which have been usually identified as high-risk groups who have to be identified as soon as possible in pregnancy and then referred to a special center or a higher center where they need appropriate specialized care. Okay, now let's summarize what we have discussed so far. So what we have talked about basically is what is antenatal care? What are the objectives of antenatal care? Then we discussed what are its components, say in terms of registration, then history, examination, investigations, then advice and services. Then we talked about the antenatal care, the clinic, what are the clinics, where they are located, and what are the services they provide by these clinics. Then we talked about the risk approach followed in pregnancy. As I said, is a managerial tool to improve the outcome of pregnancy, to make pregnancy, keep pregnancy as physiological as possible. As we said, pregnancy is usually a physiological process, but it has the potential of turning pathological at any moment in time. Thank you very much for watching this video. Thank you.